So welcome all in this session. This session would be dedicated to the basics for fellows. So basically, it's the basic for Fellows Academy. We would be discussing in brief about the various concepts that an intervention cardiology fellow should know. So I would be just discussing a few slides, that is 10 spotters that we often discuss during examination as well as while analyzing our cases in the cath lab. So this is the first cine and first angiogram and echo that is shown. So what procedure is being done? So we can see some procedure, intracardiac procedure is being done. We can see some Doppler gradients. We can see something, one catheter over which wire is there and something is being done. So the hint in this case is this patient has undergone AF ablation and something has happened as a complication. So coming on to the answer of this slide, actually the patient underwent AF ablation, pulmonary vein isolation was done, and probably in this course the patient developed a pulmonic vein stenosis, and this echo is suggestive of the gradient across that pulmonic vein, and this we could see this patient underwent the pulmonary vein stenting. So this is what is being done in this particular case. Okay, coming on to this second spotter, this is a 2D echo of a patient coming to your chest, emergency with chest pain, and this is what the resident on call did his 2D echo and he saw this finding. So, what is the diagnosis? I hope it is quite evident and everyone can interpret the finding that in Patterson long axis, we can see the hypertrophy of both interventricular septum and posterior wall is seen with some pericardial effusion. And also we can see descending aorta is there. So we can appreciate some this flap type of thing in the descending aorta. And in this view also, we can see that there is some flap again. We could see a longitudinal flap. So probably we are dealing with a situation with a concentric variant of HOCM, probably presented with the pericardial effusion due to the aortic dissection. So this is how this slide is. Coming on to the next case, this is a procedure. A patient underwent some CDO procedure, and after that, patient developed some complications. So what is being done here? So seeing that, we can analyze that this patient has developed some pericardial effusion and tamponade due to probably any small branch perforation. And to relieve the patient, this pericardial centesis was done putting a pigtail. We could see evident in the pericardial cavity. And we saw that to prevent the leakage, continuous ongoing leakage, right guiding catheter was hooked. And parallelly, a wire was introduced over that. Prograde microcatheter was introduced into the RCA, and this coiling, that is Cook Nestor coil, was put inside the RCA. And at the end, although the RCA had to be sacrificed, but the pericardial effusion stopped, and the patient tamponade was drained, and there was no further leakage, and the patient was sent home next day. So, what identified this spotter? And the hint is that this patient doesn't have a ACS. Otherwise, we could have made on right side, we see appearance, various chambers are seen in this artery around the catheter. Sometimes we may confuse with the lotus root appearance of the OCT of a recanalized thrombus. But I'm telling this is not a case of ACS or thrombosis. Then what else it could be? So it is actually a rare of the rare anomaly, that is woven coronary artery anomaly. In this, you find various intimal connections through and through, and we could see almost dissection-like appearance on angiography. So this is a WCAA, woven coronary artery anomaly. So coming on to the analysis of another image, OCT image. So this is OCT catheter. This patient has a ACS. So what is the most common postulated mechanism of ACS? So analyzing this case, we could see intima, and between 2 to 3 o'clock there is an intimal breach, and behind this we could see a evacuated cavity. So probably this is what actually on OCD we are dealing is actually a plaque rupture. So this is the plaque rupture that has led to the initiation of the Vercoe's triad and intimal injury followed by stasis and coagulation. So So coming on to the next slide, that is what is the spot diagnosis? The patient has some easy fatigability and his 2D account cath was done and this is his CAT tracing. So what do we analyze from this tracing? Most important thing is that we could analyze in the two forms. So we get a LV tracing, ventricular tracing, in which we can see there is a diastolic filling of and the pressure going up. Then we get a this systolic peak. Then there again a diastolic even, and we could appreciate that in aortic pressure, which is there is a, we can get a lower diastolic pressure. So there is a wide pulse pressure around 180 by 60. So it is we probably this is a chronic aortic regurgitation, we can make a diagnosis. So coming on to the next slide, what this pullback suggests. So many of us are aware, but just for the benefit of all, I would like to say that this first initial part shows the ventricular tracing, where there's a peak, and in diastolic there is diastolic filling. Diastolic pressures are ventricular and not elevated. Then comes a pullback, probably in a chamber. We are putting there. We are finding two systolic peaks that is suggestive of a bifid appearance. And once you pull back through the aortic valve, then this becomes a aortic tracing because the systolic pressures are high and there is some diastolic there is downslope. So this is a classical of an arterial trace that your systolic pressure goes up and there is a downward slope for the diastolic phase. The pressure goes down in the diastole. So this is probably a bifid appearance with gradient between LV and this pullback. So we could say there is a definitely gradient with bifid appearance. So probably we are dealing with a hypertrophic cardiomyopathy. So this again a patient who has a CAD, then this coronary CT angiogram was done. There was some suspicion, so he was taken for angiogram. Invasive angiography was done, and OCT pullback can be seen. So this is a still image. So what this arrow suggestive of? So we could see this is a well circumscribed structure that has a low backscatter. And so we could see it's a well-defined margin. It's a thick structure. So most probably this is the calcium. And the difference between the calcium and the lipid pool is that there is fuzzy margin, irregular margin in lipid. There is loss of signal drop there, a low backscattering. So this is seen in lipid. But here we can see a well circumscribed margins. It is almost a seed-like appearance in demand media. So this is probably we are dealing with the calcium. Again, almost a similar case. So this is intravascular ultrasound was done. So what are the most salient finding? So just we have to focus on the catheter and we could see there is a bright white echo beyond which there is a post-acoustic shadowing, there is a blackish structure. So probably this is something on intravascular ultrasound, we are seeing a 360 degree of the calcium. And the most important thing is that here the lumen is good. That means in one side there is one, two, three, there is two. So we are dealing with the calcium, which is probably deep and thick. And in this particular case, rod ablation would not help. In this particular case, we have to take this intravascular lithotripsy catheter to break this calcium, and after that, a good NC balloon dilatation would help. And coming on to this last spotter, that is it's again an OCT appearance. So what is the spot diagnosis of the picture marked in arrow? So we could see clearly that it is an intimal flap. This patient has developed some ACS due to this flap. This is some this intimal dissection is there, and the bright yellow structure, which is a linear, well described. What we are seeing inside this intimal flap is actually this cholesterol crystals, and above this, from 2 to 3 o'clock, we can appreciate punctate yellow structure beyond which there is this some radiating lines. Probably this is the shadow of the macrophages. So we are dealing with the situation where we have got an inflamed atheroma with dissection, with cholesterol crystals, and this macrophages. So this was all about the main spotters, and in the next session, I would be discussing about the 10 commandment for the intervention fellows or the 10 mantras for a successful intervention procedure. So thank you all for listening this session. Thank you.